Шановні колеги, відкриваємо клінічну сесію номер 1.
So, dear colleagues, we open the first session, clinical session number 1. We invite Alexander Shulak, and he is urologist physician, deputy director of Institute of Urology named by academic Vazyanov. And hello to all. I'm happy to see you all, and I would like to tell you the greetings from Institute of Urology from academician Vazyanov and academician Lisovy. Maybe you heard about them. And today I would like to speak about the problems because of which you gathered here. So more than 80% of the people with SCIs, they stop control of the bladder, and it's very often when the incontinence is seen. So I would like to show you the results of research which was presented in April 2024 at the Congress of Urologists. So the therapy of appendixes, can it help? So we showed the research we did among the men, which is not so often. Some methods can be even better than modern approaches. This approach was treatment of empty bladder, and we saw that the therapy with mobile application helps the lower urinary tract treatment. And the full results of research will be published later in this year. And the professor from Freiburg from German explains that the problems of bladder they are most spread. And we didn't have enough very substantial support, and by data now we see this data, and this data in a digital way, and there were 237 participants, and they obtained standard treatment, and the others they got the treatment with application together with the standard treatment, and they had to keep the diary and inquirements. Questionnaires about the difficult parts of their life. So then we saw later the better life situation of those who received with digital application by several percent, and we saw that therapy with application was more efficient, and none of the patients responded about the side effects. So this is the challenge to what was done since the 1970s, and many men with problems of bladder, they get older, they need to be treated, and they need to be getting different treatment, and sometimes there's some drugs that do not go out because of side effects. And those who use the digital therapy, they know they don't have the side effects, and they don't have the additional treatment as it was before. So Jean-Nicolas Carnot, the urologist from Charles-Nicolas Hospital from France, said the comment in this research: we don't have enough evidences how to control the bladder by men, as it is said in the hospital. But this is the first research of behavioral treatment which showed positive results, and it could become the first step in changes in paradigm of treatment. And Professor Cornu said that we need more massive research to see how the digital application can help in treatment of bladder, and if such a treatment is proposed in a broader way, it can change the practice in a dramatic way, and we will not be necessary to give additional drugs. And the researchers they compared and showed the results of different results, and all the patients got the advantages, but the Coronus Herzica was also of this application, and it was not independent. It was independent according to the applicants. And I would like to come to the second part. The phase of my speech. I would like to tell you about the transformation of medical health in a system in the European Union, the manifesto of policy of reform, the new project of European Association of Urologists who work with European Parliament and Commission through a political office that was created 5 years ago for this targets. So European Association joined the office about the policy in the EU. The manifesto was presented at the first summit in Brussels to persuade the politicians to move. So you see the original manifesto signed by these organizations. Why we needed to do this manifest? Because 60 million patients suffer from the problems of incontinence of bladder, and this problem influences the society and environment, and the outcomes of problems with bladder they are felt by all sexes and ages, and can influence negatively the quality of life of people, physical, psychosociological, for patients, and they prevent them from to live fully in the society, accompanying illnesses are always related to cancer. The key issue, how to do prophylaxis of incontinence, and because it is not introduced in the full scale, so the low quality of life is a burden for the families and the tutors of the patients, and medical professionals do the best to work in the modern system, but the modern systems they are not adopted to the constant care, and the politicians in the EU they don't pay enough attention. And if we take measures, if we don't take measures, this problem will increase in Europe because of the aging of the society. So the signatures of this document, they propose the 10 main steps, and to solve this problem. The first step to develop the complex strategy in EU countries, to develop the strategy which is aimed at the patient, which will include the approach to the patient. This strategy should include the innovations and the changes of the approaches, and also use more prophylaxis, and bladder health should be integrated in the policy of EU, otherwise it will not work. Step 2, to give the access for people to medical care, to improve the treatment, to support the expenses, and people with incontinence of bladder, they should have access to facilities, and such a treatment should be affordable without additional cost for patients. Step 3, to guarantee the access to toilets in urban in the public places. Step 4, enough medical professionals for all patients. Step 5, to finance the decisions in the health care. So the health care should be sustainable and should be ecological. The priorities should be ecologically grounded for patients, including the innovations like ecological clean technologies of Pampers and disposal of waste. This is a very big ecological problem. Step 6, to support informal take cares. And seventh step, to improve the understanding between incontinence and aging, which influences the mental and neurological health, also obesity and so on, and adaptation of treatment for the needs of every person. Approval of financing the researchers. You know that the researchers are not enough, and the finances is not quite big. Step 9, the awareness campaigns for the public, because the public doesn't speak about this program, and this leads to stigmatization, and the public should understand the symptoms and to understand how to get approach to the solutions, and information on the advantage of support of bladder health, and this information should be spread for the population. And the 10th step, that the healthy movement for patients. So the expert from Germany says it's the time to act and solve this problem, to solve it on European scale, and this is the call for actions. We wanted to inform the politicians that there are many ways to find the solutions to have access to treatment, and including treatment and inclusive environment. We need to invest more for solving this problem, to reduce the burden on caregivers and patients. Thank you very much, Ukraine and Ukrainian Association of Urologists. We signed this initiative in November, this memorandum, and at the Congress of Association in June, this manifest will be presented, and public organization could be capable to sign it. And what we do at the conference at the 15th and 17th July in Kyiv. Welcome to all in Kyiv. Thank you.
Thank you, Alexander. Next presenter, Dr. Trifoniuk Lilia. The floor is yours. Dear conference participants, the pictures which are shown and the decisions that doctors may receive about condition of the patient may also be a nightmare for doctors who treat urologist. Necessary condition for urodynamic investigation is the complete understanding of lower urinary tract function and anatomy. Bladder and urethra are lower urinary tract, performing reservoir function, accumulating, and also voiding function, also ventilation function, preventing reverse movement of urine. Volume of bladder is under 300 milliliters. What makes urinary bladder unique? Constantly changes volume but keeping stable low pressure. Beside that, lower urinary tract, as we usually say, is the combination of container and conveyor. They should always work in cohesion, and the main component in that is played by wall of urinary bladder that we call the trouser, which is one of the main moving parts that helps support normal pressure. In order to understand the act of urination, we need to understand well that it's not one stage. It is made of a phase of filling and phase of voiding. Phase of filling is characterized by the trouser being relaxed and all the sphincters are contracted, so tense, so the pelvic floor muscles are also tensed. In the voiding phase, when we have first urge for urination, we try comprehensively to slow down this urge. All the structures continue working the same mode and nothing changes, as we have a conscious control of that. Then when even more urine appears, normal reaction is to void urinary bladder and the phase of voiding happens. Voiding phase is characterized by the trouser being contracted, sphincters being relaxed, and pelvic floor muscles are also relaxed. Physiology of urination. In the first place, we will consider normal anatomic condition when urethra is functioning normally. Phase of filling, the trouser is always in stable condition, so always stably relaxed, irrespective of how much urine gets into it. The main condition is low pressure and a good possibility to distend and no irritations. Ability of a bladder is to keep constant pressure despite number of urine that gets in it. Keeping the same, I try like Irina maybe to place microphone. Do you hear well? Should I add? Okay. So the filling phase, main objective of the trouser is to keep stably low pressure irrespective of how much urine gets in. 50 milliliters gets in urinary bladder, the same tonus. 100 milliliters of urine comes in urinary bladder, again the same pressure. This is called good compliance, so accommodation ability of urinary bladder to support stable pressure irrespective of number of urine reasonably gets into it. The phase of voiding, opposite, the trouser starts stably contracting. Normal condition, normal urination is for the trouser when it started stably contracting at some point till the end of voiding phase. It should be kept constant, uninterruptible at the same level. At this time pressure becomes normal and the complete voiding takes place. Neuroregulation of urination is pretty difficult. We're not going to dwell in detail on those moments. I would like to say that this is regulated by sympathetic and parasympathetic nervous system, and failure at least one of the components at any of those levels always leads to irreversible contraction and influences the function of the whole system in general. With physiological urination, all the phases are maintained. Phase of filling, phase of voiding, have a certain time lapse as well as some numerical indicators, and depending on those phases, depending on changes we should consider or to look again at some problems with urination. So when urethra works normally, completely it gets occlused if it's got pathology, it does not keep urine, we have leaking container, so to say. Feeling phase, as you remember, the TRUSA was stable. When the problem appears, irritation of the TRUSA happens and the TRUSA starts to actively get rid of urine. No matter how much urine gets, it may be 20 milliliters and cause uh, urge, strong urge for urination. 20 milliliters, 50 milliliters. If this urge is very strong, we might have so-called urinal inconsistency, and we have may have frequency urgency syndrome. If we have problem with pressure at this stage, when it becomes too high, we have return flow on urinary channels, which is a serious problem. Also, we may have rigidity of urinary bladder, inability to expand if more urine gets in. We may speak then about bed compliance. Why? Because English language word compliant does not have corresponding exact word in Ukrainian or other Slavic languages, and very often many languages do not translate this term into their languages. At the phase of feeling, where the TRUSA had to contract, we may have unstable contraction of the TRUSA, hypotonus. Avoiding phase, we may have obstructive component, where we have low pressure, we have hyperactive TRUSA. When the incomplete voiding happens, we may deal with residual urine. If we have problem with urethra, we may have obstruction, so-called dull container. If we have neurological damage, it is even more difficult as the initial pictures. And just to say that the patient who entered in wheelchair having disease A, disease B, disease C, patient may have several combinations. At least 8 combinations are possible that may combine for the same patients often or be manifested different stages differently. The most imminent situation that we as urologists face with neurological problems is autonomous dysreflexia, which unfortunately very often we may cause whether by our manipulations or by our interventions or by untimely organization of urological problem. Typical spinal patients have a node sensitization lower than thoracic vertebra, doesn't feel anything, no response to pain. This patient does not complain of any pain. Super ideal, unfortunately no. If such patient has full bladder, it responds to the system of expanding. Expansion system does not only leads to renal accumulation of urine instead of voiding, so we may have atrophy or other things. At the first place, it leads to vasoconstriction that influences arterial hypertension, that influences also indirectly to baroreceptors, and we may have patients who have full urinary bladder. From the other side, we have increasing arterial pressure, also higher spastic tonus. Yesterday we provoked such moment from patient that Mr. Ruth was studying in urodynamics, and this problem we had to resolve for several hours. The studies continued for 20 minutes. Patient who was not quite stable and had many problems were trying to resolve within several hours. So we should be rather careful with our neurological symptoms range. I don't know if we see well on those slides many reasons that may provoke this dysreflexia, but from urological ones, the first place, complete urinary bladder problem with voiding urine, obstructive problems, inflammation processes, septic processes. This is what it seems, and maybe called as like silent urology. Pretty imminent condition also in our urological practice with the neurologic patients is the trussosphincter dyssynergia. sounds like good terminology, well described, but such patients are pretty difficult. At initial stages, we are unable to find for these patients because they do not have purely adequate primary picture of condition. Usually those patients arrive in the neglected condition. Yesterday, Ruth demonstrated us what seems simple at the first place. Generally, turns out to be pretty difficult. The detrusor sphincter dyssynergia is when the detrusor starts contracting actively sphincter at the same time instead of relaxing and giving away urine, slowing it down instead. And we have at the same time two toni that work one against another, and they do not have unity how to work. So to say, container and evacuator do not cooperate at all. And as a result, those patients die with silent urological death from kidney dysfunction, septic things, or as a rule show up for urologists at the terminal stage. If possible, to launch video. Okay, the pictures were introduced here that characterize a patient. Cystography shows full urinary bladder with 500 milliliters contrast substance. In this case, patient could have returned to kidneys reflux, but the wall of urinary bladder is changed so much we have a complete obstruction at the lower part of urinary tract, and our part hypertonus and don't give urine completely towards the urinary bladder. Yesterday, urodynamics, this patient without the previous medical history, without previous investigation, looked ideal. The truth have the complete capacity, having tuberculosis, has some responses to stimuli, to irritations that we induce, but as a result we have a terminal patient who requires video of urodynamics. It cannot be considered only in the context of simple urodynamic investigation that will not provide us the full picture. Algorithm of urological assistance is very complicated, detailed in many nuances, but anyway, patients who are not in spinal shock, they survive this active phase, require aerodynamic studies. All 100% patients require aerodynamic studies, having two objectives. First, to know what they have at the output, if they have problem or they don't. If they do have problem, which is the problem and how it can be resolved and in which method. So coming to time frames of aerodynamics, very often we hear that aerodynamics is when patient arrives, urinates somewhere, receives some super complicated picture with the graphs. Even better, making small picture as a check. Super, I made urodynamics. The doctor wrote that patient went through urodynamics. Unfortunately, that's not the way, just a component of comprehensive urodynamic studies. Next I will tell you the name. Component of urodynamics that we often speak not only from the conference chair is studies not with the help of endoscope, not investigation with the help of endoscopic cameras or typical visual control. So urodynamic methods of studies may be subdivided into invasive and non-invasive. Non-invasive is a book of daily urination, urovolumetry, residual urine. We use ultrasound centers, test with in-lanes and electromyography. Invasive methods, we include systometry, determining the pressure of losing urine, flow metering. Catheterization may serve as invasive investigation method, and electromyography with different types of electrodes. mushroom-like, for instance. Day book question is very important. It's not just 2 or 3 papers we ask patients to bring in. Often we receive information at the initial stage that enables us to understand better if we have hyperactive component or have the suspicion of incontinence in this day books of urination. We need to have this day book of urination at least for 3 days, which is completed 24 hours format. We have the volume of avoided urination, like 24 hours diuresis, abdominal condition during urination, need or using the in-lanes, number of liquid the person drinks, also the number of procedures, how often person tries to get procedure of avoiding urine. A pot test is the test of world community of urine incontinence, requiring more than 1 hour, because before that person needs to drink liquid for 15 minutes. So as a rule, those patients require 2 hours to studying, but the hour when this test is performed, you need active physical preparation. Have some physical exercise, 30 minutes walking, going up, going down, provoking cough, and bringing up small objects from the floor. Then it is weight in advance and potential number of milliliters of urine calculated that were lost. Ultrasound investigation of kidneys. We study if the kidneys are expanded and residual urine remains. We may use portable ultrasound scanners. Hospital has a pretty compact ultrasound scanner with a tablet. Tablet is a bit bigger, otherwise it could fit into our pocket. Standard determination for the residual urination norm is up to 30 milliliters. Up to 100 milliliters we should interpret it as clinical. Over 150 milliliters is always pathologic value. Electric myography with the on-skin electrodes is a standard procedure. So what people often speak of urodynamics is uroflow metering. Uroflow metering meaning that patient urinates in intimate, comfortable condition. Shouldn't have any additional personnel, some additional people who would distract person or would make person shy. So the atmosphere should be comfortable. Person is urinating into special container, also called electronic pot, and the machine is building the graph of urination based on the process measurement. Today those devices are Bluetooth connected, enabling to install in patient rooms and to connect to certain patients that we remember 10 years ago patient is connected to patient with a cord, seeing the way they urinated, or the patient does not urinate at all when the doctor is looking at the patient with the grim look. So based on urine flow metering, we build the schedule of urination. In all practice, we use the main indicator Qmax, maximum volume speed of urination that patient achieves, that initially speaks of many pathologies and eliminates many questions at the initial stage. The patient arrives, the schedule starts that the machine is building for us, starts from the time where the patient starts thinking about urination, start preparing for that, starts urinating bit by bit, urinating with maximum velocity, so the velocity stops dropping gradually, and by less drop of the urine, machine as a rule automatically stops a calculation, or the patients have additional control Then we start from investigation or finishing or some voice commands that I started and I finished. The maximum volume number of urination is different for male and female. For female till the age of 50, optimum to have the urination velocity 25 milliliter per second. More aged women, related to many problems including neurological, norm is considered to be up to 18 milliliters per second. For male, those indicators are different by 40 to 22 milliliters. Over 60, 13 also norm. Unfortunately, it wasn't me who made up those indicators, so allowed you to urinate a bit worse with age, and this is considered to be norm. So flow monitoring has those 10 indicators, but building this curve right away with the help of automatic computer, we may combine the type of urination. It may be normal, intermittent, interrupted, very fast, or destructive. May speak right away about some possible pathologies. Comprehensive urodynamic studies is made of uroflowmetry, profilometry of urethra, flow speed, pressure, systemetry, made a phase of feeling, functional, and phase avoiding. But there is one remark in all that these studies may be done both horizontally as well as sitting as well as standing. This needs to be taken into account because for those indicators, depending on positioning, we may have different criteria of normal pressure. So urodynamics is at the first place. To speak of urodynamic studies and systemetry for patient, special darts is connected. This is special catheter. A majority of cases having two channels. One channel is necessary to supply water, other is necessary to measure pressure in urinary bladder. And second prerequisite, beside the measure pressure in urinary bladder, we are to measure pressure in abdominal cavity. 21st century, it would be not very humane to make some additional orifice in abdomen just to measure pressure in abdominal cavity. So scientists learned to use natural orifices. For male, those are rectum, for ladies rectum or vagina. Additional component which may be changeable, electrodes that we use for electromyography. So for urodynamics we need 3 electrodes: vesical, rectal, vaginal, and definitely electrodes for electromyography. To have it absolutely complete, those electrodes are installed into one of those cavities. Special liquid is supplied and the schedule machine starts building some schedule, filling a urinary bladder. All this complex system enables us to see how well urinary bladder is expanding, how well bladder responds to water that we supply, because we supply liquid at a certain velocity, how well it reacts, does not give us some feelings, how silent it accumulates liquid without showing some symptoms from other organs. We see how good compliance is. During the process we study stability, how well urinary bladder function, how well detrusor function, and indirectly we receive data about sensitivity, how to which extent it does not react to some side irritators. This machine, which is very smart, software automatically calculates number of supplied urine, liquid we supplied, and the indicators the first sensation of feeling. When patient feels first urges for urination, we need to determine manual. As a rule, is when we have 100 or 150 milliliters, we need to indicate here first urge for urination. So one person wants to go to toilet. One person's got the desire that cannot stand to go to a toilet. And where is the sensation that we call among regular people like crossed feet? Also episodes of leaking urine, urinary bladder, pressure that we record by a blue catheter, pressure in the abdominal cavity. Also we have at the end the pressure of the detrusor calculated by machine, difference between pressure gained in urinary bladder and pressure in abdominal cavity. This is calculated from those two indicators, and we receive the initial picture like that. In feeling stage, what we were speaking about before, first picture, how urinary bladder is filled. Myography indicated by red. Biureter and sphincters respond well to all those irritation indicators. Phase of voiding, the way the detrusor responds, our urinary bladder responds to the irritators. It receives how stably urethra is to be open and how well muscles of urethra react. Beside that, we also have a pretty long methodology, manual cystometry or by eye. It helps in clinical practice, described in textbooks, helps often in centers where we do not have urodynamic studies. We install catheter into bladder, Geneva syringe fill, provide level to a certain level, a certain speed, and if this level goes up, we have the indirect data for the components of hyperactivity, but again this is systometry by eye in daily practice. Measuring myography of pelvic floor made by connecting red and green electrodes in respective places. Urodynamic studies video is not a study with endoscope. This is study with the help of X-ray investigation methods, but with using construct substance. This is X-ray, this is not endoscope. As a rule, we use pseudo. Also classified depending phases of filling and voiding. Main indications are urine incontinence, because at the first place it seems like urine is leaking and leaking. It may be related both with the detrusor as well as sphincter problems for male. Beside that, the problem with prostate gland may head up. Beside that, indications for ultrasound studies, hyperactive aneurysms for the adults. Before the procedure, we definitely need to have sterile urine, and everything that seemed yesterday inachievable seems for us the target we have achieved already. Thank you.
Also thanking for stressing the importance of urodynamics, because without neurourologics you can't think about neurourology.
So, thank you for your kind words. Дякую за чудові слова. Дозвольте мені представити
Thank you for good words. Let me present Professor Ruth, who didn't only decided to be our guest, but she worked for 2 years with the Spinal Center, and she helped us to introduce this dynamic in our everyday work. But with her very wise recommendations, she saved not only one life. And thank you for your word, and please come with your presentation, experience of implementation of urodynamic. Pitfalls in urodynamic assessment, international and local experience, please.
So maybe I can just say a couple of words to my person. My name is Ruth Kirschner-Hermans, as you have heard. I'm head of neurourology of the Johanniter Neurological Rehabilitation Center. I'm a university professor of the University of Bonn. As a university professor of neurourology, my goal is to help to build up neurourology in Ukraine, to build up neurourology from academics to clinic. I'm still waiting for my slides. But I can still tell you something. Oh, yeah, you can go over the, next slide, please. Where do I have to point it to? Okay. So I can't tell you how glad I am to see my slides in Ukrainian words. Very glad. But on the other hand, now I can't read my own slides. So please excuse that I use my script to be, understandable. And so let us first mention Sir Ludwig Guttmann. He was born in Upper Silesia, 1917. He was a German neurosurgeon who fled to England during the National Socialist era. He was not only founder of neurourology, but also 1960, founder of Paralympics in Rome. Until the First World War, the mortality rate for patients with spinal cord injury was around 90% in the first year. But due to his findings, we nowadays know about the benefit of the bladder as a low pressure organ and the value of catheterization. My talk today will mainly focus on prevention. Prevention of losing the bladder as a storage organ and preventing kidney failure. A large worldwide study done by the Swiss Paraplegic Society revealed that in countries with no or poor neurourological care, spinal cord injured patients often die after 4 to 5 years, and only 10% are integrated in the working society. Very different in countries with good neurourological care, in which 60% work and life expectancy is close to normal. Spinal cord injury interrupts the proper bladder and urethral sphincter control. Nearly all patients with SCI suffer from lower urinary tract dysfunction. They develop a urodynamic bladder. Lower urinary tract dysfunction leads to long-term complications, such as recurrent infections in the urinary tract, recurrent polyonephritis, urolithiasis, and to upper urinary tract kidney damage, and eventually renal failure. Good neurourological care is mandatory for quality of life and life expectancy. And I say it again, neurourology is not so much about treatment, it's all about prevention. To quote EAU guideline, renal failure is the main mortality factor in SCI patients who survive the trauma. Keeping the pressure during both filling and voiding phase within safe limits significantly reduces the mortality of urological causes in these patients and has consequently become the top priority in the treatment of patients with neurourological symptoms. In order to prevent upper urinary tract dysfunction, it is necessary to classify lower urinary tract dysfunction. Based on these findings, we need to develop individual storage and emptying concepts. We need to evaluate risk factors for developing kidney failure. And it's only by using urodynamics, as we already heard by Lilia, we can classify lower urinary tract dysfunction. Urodynamics is also necessary to evaluate risk factors. The essential of urological care for SCI patients are accurate diagnosis, treatment planning, prevention of complications, monitoring and adjustment of treatment, and very important, education and counseling. There is wide consensus with these guidelines. I was co-author of the neurourological guideline for the German-speaking Society of Paraplegics, which is the only guideline focused only on spinal cord injury patients. To summarize, our goal for SCI patients is to preserve renal function, to achieve sufficient bladder storage capacity, to prevent or at least reduce the number of UTIs, and if possible, of course, improve quality of life. I think I have the wrong. In most patients, this is the wrong slide. Is this not the don'ts and do not? That is slide 17. Okay. So I will come back to this slide later. You already saw this scheme in Lilia's talk, and it describes how the different lesions provoke different disorders of the bladder. Most patients with spinal, infrapontine, suprasacral lesions, we see both storage and voiding symptoms, as you see here in the... I'm sorry. As you see here in the yellow highlighted field. That's the condition we're talking about. It's a spinal lesion. So it's infrapontine and suprasacral. This is a typical urodynamic measurement in the condition with phasic detrusor overactivity and insufficient emptying. This is rather reflex urine loss than real micturitions, real voids. In the first line, we see vesical pressure. The second line documents the rectal pressure. And the third line, as Lilia already mentioned, is a subtraction of the abdominal pressure of the vesical pressure. And with this calculation, we get the pressure of the detrusor. And you see, at the same time, detrusor of overactivity, a reflex micturition, the fourth line, occurs. And although in this example, there's hardly any residual urine, you see also in the fourth line, the risk of kidney function loss is immense. or we see pictures like this. This is a typical urodynamic measurement of a neurogenic low compliance bladder. In the X-ray, you see the external urethral sphincter contracts and the detrusor pressure rises with the filling of the bladder. You also see the beginning of diverticular, no reflux, but the kidneys are nevertheless endangered by the high pressure in the bladder, and probably also because of the morphological changes in the bladder wall. First-line therapy is a lifelong antimuscarinic treatment or second-line use of beta-3 agonists such as mirabegron. And remember, in the neurogenic bladder, doses are often higher than recommended. In some patients, side effects can be reduced by using intravesical oxybutynin, at least in patients who use intermittent catheterization. There are strong guidelines recommendations use as second-line therapy botulinum toxin injection in the detrusor to reduce neurogenic detrusor overactivity in multiple sclerosis and in spinal cord injured patients if antimuscarinic therapy is ineffective or patient faces too many side effects. Sacral neuromodulation, I know we will have another talk on neuromodulation. This is recommended in sensomotoric incomplete spinal cord injury. Can't be used in complete spinal cord injury. And it should be tested positive before doing it and recommended earliest 1 year after trauma. In Germany, this treatment is off-label, and it is unclear who benefits most. But it's of course important that we do clinical studies to investigate in this very promising technique. Bladder augmentation and urinary division are the last options to save kidney function. Sphincterotomy is irreversible and should be limited to men who are able to wear condom catheters. In patients with detrusor activity sufficient for a reflex micturition, a catheter in those patients can be spared. By staged incision, bladder outlet resistance can be reduced without completely losing the closure function of the urethra. The incision with less complication is a 12 o'clock sphincterotomy, either with cold knife or neurourological laser. In many patients, sphincterotomy needs to be repeated at regular intervals, but is efficient and does not cause severe side effects. Honestly, I think sphincterotomy can be a good option for selected patients. This is especially true in a country with limited access to botulinum toxin. Now I wanted to have this. So now I want to talk about what shouldn't we do. Bladder training, clamping the bladder. The bladder cannot be trained by clamping the catheter, but a lot of harm can be done. And you have to be aware of that, especially if you haven't done any urodynamics beforehand. In patients with high spinal cord lesions above T3, in some even above T6, you can provoke life-threatening automatic dysreflexia, as Lilia already explained. You can easily overextend the bladder, especially if clamping is not controlled for bladder filling, and polyuria, common especially in higher lesions and in the first year, is overlooked. And obviously, in uncontrolled spastic bladder, increased pressure by clamping the catheter in those patients, you can create an increased risk of kidney damage. So no bladder can be trained by clamping the catheter. Now I go. Now I have to find my... Let's now talk about low pressure, as we find in patients with complete subsacral lesions and conus cauda syndrome. In most patients with subsacral lesions, we see a good bladder storage, no detrusor overactivity, but voiding is not possible. Here is a urodynamic example of a patient with an atonic detrusor. We don't need pharmacological or intravesical treatment. First line treatment. The truth is there are no sufficient drugs for underactive detrusor. All guidelines agree. Do not prescribe parasymptomatics for underactive detrusors in spinal cord injured patients. Of course, alpha blockers can be prescribed to decrease bladder outlet resistance, but they will rarely solve the problem. Abdominal straining and overextension of the bladder have to be avoided. So, nearly all SCI patients are dependent on catheterization. Better than indwelling catheter is, of course, the use of intermittent catheterization. And suprapubic catheter is better than transurethral catheter. If incontinent, surgical procedures like suburethral sling, preferable with autologous tissues or on an artificial sphincter at the bladder neck, might be possible. But be aware, catheterization must still be possible. The golden standard is intermittent catheterization. For all patients who are unable to empty their bladder, that's a very strong recommendation. But besides sufficient hand function and strength in the triceps brachii, there are other prerequisites. Motivation, visual acuity, cognition, anatomy, and very important, expert instruction. And that's where we need nurses. We need nurses to do this instructions of the patients, to tell them the right technique and advise them on catheter models. But I can assure you, after completing the learning curve, we usually find few complex complications and infections. Neurourological disorders are often unstable and symptoms may vary considerably, even within a relatively short period. We have to assess the upper urinary tract, the kidneys at regular interval. In high-risk patients, annual urodynamic checkup are recommended. Renal diagnostics should be done every 3 years, either measuring the glomerular filtration rate or using scintigraphic methods. Education and information of the patient about the type and signs of complications and active cooperation are required. Under these optimal conditions, paraplegic can achieve a life expectancy with little or no restrictions. All recommendations are based on EAU and AUA and the recommendations of the German-speaking Medical Society of Paraplegic, which I co-authored. Thanks for your attention. I'm very grateful to the Ukrainian nation for their bravery in withstanding this awful attack. Not only on your country, but also on our values. If we can help to improve care for veterans with SCI who fought for our freedom. I'm very thankful. Slava Ukraini.
Так, окей, пліз. Прошу дуже.
We cannot even translate without a microphone. We cannot hear the question.
Very, very good question, but I will have another talk only on botulinum toxin.
Any questions on the floor? Дякую, тоді ми продовжуємо. Дмитро Дмитрович Раскевич.
Thank you. Then we continue. Dmitro Raskevich, rehabilitologist, doctor, also moonlighting urodynamic investigation doctor. Very honored to speak also with the urologist doctor because I'm a doctor of physical and rehabilitation medicine, and to a certain extent I may represent my colleagues. We are many, and I want to say that a very good great presentation. At the first sight they might seem very complicated, so many nuances. Injury of spinal cord, and this is only urinary bladder. However, physical rehabilitation medicine, physical rehabilitation doctor within physical rehabilitation medicine is to understand all of that also. Please give to me. We have a bit shift. I'll try it faster. We'll speak about experience organized in our place. Urodynamic laboratory was organized in our facility. It was implemented by prism of physical and rehabilitation medicine. In the rehabilitation community we have several topic area, for instance testing, discussions in the world, who has the right to do, who does not have the right to do that. I would like to go to qualification characteristics of physical and rehabilitation medicine doctor. Huge list, among them evaluating function of the sphincters and interpreting urodynamic tests. So to get oriented on our own, usually to get the condition of the urinary bladder, urologist doctor was needed. Now when we speak about rehabilitation medicine, physical rehabilitation doctor on his or her own may make a decision when the condition of bladder is outside the situation. Close cooperation with the urologist doctor, very close cooperation. There is some situation to give away something and not to come back anymore to that, and then to resolve healthy resolved issue. And then the urologist doctor, urodynamic with urinary bladder is also his or her area. You know a little that injury of spinal cord injury and rehabilitation of spinal cord injury started like in many other places in 2014 and 2017. Rehabilitation of spinal cord injuries within the Republican Center of Neurotrauma Rehabilitation, as it was called back then, until the 1st of January this year. And then 2019 we had first doctors of physical and rehabilitation medicine, and urologists. The doctors officially received so to say some assistance from colleagues will help within rehabilitation to figure out problems related to urinary bladder. And I will put it this way: in 2019, in 2020, when we started expanding the prism of physical rehabilitation medicine via biopsych model, searching to exemplify, we know that Rivne Regional Hospital, we were opening a lot, studying the examples and achievements a lot. But when we look and see that urodynamic studies in the world determining functional possibilities of urinary bladder, recognized urodynamic investigations, I will tell honest, in 2020 I knew that it was very important. I didn't know the way it looked like. One, within the support from WHO, developing rehabilitation as a result of spinal cord injuries using our facilities within the interdisciplinary team from WHO colleagues that joined us 2022. Alex Rose, doctor from United Kingdom, physical rehabilitation medicine doctor, visited us, asked a lot about urinary bladder, how do you do this, what you do that, reached the point of urodynamic testing, that this is necessary and how important it is. It was October 2022, May 2023. Factually, within setting up and writing work on rehabilitation as a result of spinal cord injury together with WHO, the laboratory was launched, the equipment was procured, and Dr. Alex performed the first training, basic things, urodynamic studies you have seen in previous slides of the presenters, how cumbersome and how important it is in the first place. We launched first urodynamic studies, and he had first urodynamic trainings for us. Next, fast time goes fast. You notice it all. November 2023, a visit of esteemed Dr. Ruth and organizing regular supervision support of urodynamic studies within cooperation of WHO with charity organization Razom for Ukraine. You may also see certain version 1.0 of urodynamic laboratory to the right. Next, constant weekly meetings via Zoom and possibility to discuss plans or the investigations performed by physical rehabilitation doctor investigations during this constant weekly meetings till now turned into next so say Lilia Irina joined. You may see the new neurodynamic office, new urodynamic chair, so to say. This is version 2.0. Everything's well, and I think that urologists, doctors, physical rehabilitation medicine doctors who will be the most related medical nurses, we will try to organize some small visits so that see with your own eyes, not to hear something here but also to see. And Lili Irina, esteemed urologist, doctor, recognized a huge support. I would like to show our Saturday meetings because we couldn't meet other work days to work together on improving rehabilitation assistance via urodynamic studies. Can you turn this on, please? Good. Thank you. Thank you. Thank you. This cooperation continues and strengthens for the future. Also, I hope May 2023, yesterday. Once again, visit from Dr. Ruta Lili, you all and we at the stage of a significant event for urodynamic world, urologic world of physical rehabilitation medicine, spinal cord injuries. This is our topical area. We have organized, as it has been mentioned at the beginning by speakers, that we do not take anything new. This is what works. We do not invent new wheel. We organize it using our facilities. So we do not hide it from everyone. We set it up and running and create the database of knowledge, cooperate with everyone to disseminate this knowledge throughout the whole Ukraine. Thank you for your attention. Thank you so much. Next presentation, Alexey Alexeyevich Bizmenyak, Doctor of Medical Sciences, Chair of the Department of Clinical Medicine, Rivne Regional Hospital. We will delay ourselves in time, but lunch will not go away from us. Thank you.
Good afternoon, all. I would like to thank our colleagues who invited us and to share the experience and knowledge. And I would like to thank the previous presenters and that several points were already shown. It will make my presentation faster. So, possibility of conservative therapy of urinary system pathology and spinal cord injuries. So the SCI can be also caused by different factors. It could be trauma, it could be infection, it could be bad blood circulation, and globally the level of illnesses is from 3.6 to 191. In the US is 40 per 1 million, and in Europe it's from 13 to 19. The first period is from 13 to 32 years old, and the second period is up above the 60. In younger is the road accidents in the older categories falling down. So also we should point out that the most spread were the sclerosis, the Parkinson disease, and the stroke. 40% they needed to go to hospital two exams, 33 for hospitalization, and 15 should stay at home. The amount of urological complications is big after the trauma. So if the trauma is before the 25 years old, it will be between $6 to $13 million. So every person should have his or her own program, which takes into account all aspects of life activity of the person. So the previous presenters, they showed us the anatomy and innervation of urinary tracts. So I would like to say that the cortex is working with the signals. So the different segments of spinal cord, where the different signals and different controls levels are activated, and this is how the innervation of the bladder is going on, and that of urethra. If we look at the sympathetic and parasympathetic innervation, we see that sympathetic through the nerve makes relaxed the detrusor and the neck with parasympathetic through the bladder bottom and others noradrenaline, beta adrenaline, and alpha receptors at the neck and the rest about the parasympathetic with the truth and other mediators with sympathetic innervation. The nerve contracts the external sphincter. As for the physiology, through difficult paths where the feeling of the bladder is controlled, the hypothalamus and the brain, the decision is taken for emptying. If it is stimulated through sympathetic nervous system, the bladder is filled. When the impulse is received through parasympathetic system, the detrusor is relaxed and the neck and the emptying is taking place, and then the period starts and feeling of the detrusor as what is going on during the spinal cord injury. You saw already this slide, and similarly we can speak about the damages which can take place in the bladder. So if upper sector, we will see the urination. If we see the lower part injuries, we will see the symptomatic, and if it is at the level of sacral center, there will be symptoms of feeling function of a bladder and prevented urination. So we saw this curve already at the different levels of injury. We see the state of detrusor and sphincter and their combination. As for principles of treatment of the bladder, so depending on the symptoms, we will use medicinal or catheter therapy. If we speak about the feeling, we will use the replenishment with lower pressure and elasticity and function of emptying. If we speak about dysfunction of the urination, when the bladder is contracted, but dysfunction is of the sphincter. So we also said that these dysfunctions can lead to the death of our patients. So we spoke about the dysfunction of the mediator, and at the first line we can use the drugs which are the antagonists of M1 and M2 drugs which are in the walls of the bladder. So the blocking leads to the reduction of retraction of bladder. As for the feeling function and better feeling function, so we can speak about stimulation of beta receptors which are in the walls of the bladder, and the muscle of the detrusor is relaxed, and it leads to treatment of this energy, and it was proposed as the second line of treatment. Also, third line of the therapy of the use of analytics and receptors. These could be botulinum toxin, and later we will speak about the botulinum toxin in the ureter. Also, feeling of urine during the day also may be connected to the less irritation of the detrusor, and it reduces the signals for the urination. So if we react to the feeling of the urine, we can look at the stimulation of different nerves which are at the lower place, and such researches were done in the 90s, and now they are continued as for the dysfunction of the urination. When the detrusor is working, the sphincter that allows to get rid of the urine, and alpha adrenaline blockaders are used to catheterization of bladder. And today there is tissue re-engineering is proposed as for blockaders, taking into account that receptors in the neck of the bladder, and the blockaders, if they used, they can improve the emptying of urine from the bladder. As for the Botox in the sphincter, it reduces the function of the ureter, and some other types of treatment can have other results. So the Botox in the ureter should be studied more. As for catheterization, intermittent catheterization can be used, permanent catheterization and catheter drainage through the condom can be used. As for the intermittent catheterization, as was said in the previous presentations, to use such a catheter, it should be fully sterile, but it was so difficult, so we came to the understanding of the clean catheterization, and it doesn't increase the infection aggravations. And it is recommended to use every 4-6 hours clean intermittent catheterization is the golden standard today in the treatment of the pathology of the sphincter, and it allows to be closer to physiological state. It is used for SCI patients. In the 70s, it was proposed as clean catheterizations, which is proposed today for use, and everyday antibiotics are not recommended for prophylaxis. So it's enough to use every week perorally the antibiotics, and antibiotics in the bladder may influence the function of the bladder. And also there was a research which showed us that because of the reduction of cost, the cassettes were used for several times. So the time was shown that in Indonesia the cassette was used for 3 years. So then the cost is reduced from $4,000 to $18 now, and sometimes in some hospitals even glass catheters are used, but periodic catheterization, which is considered as the golden standard, 42% in use such intermittent catheterization, but there are other patients which are using other methods, and 1992 there were research saying that periodic catheterization will be kept with 5% of patients, up to 30% of patients, because they don't like it and it's not easy, and some people they refuse from periodical catheterization, or they give the preference to cystonomy, and so we consider that that people will transfer from periodic catheterization to permanent catheterization in 11 years. As for the permanent catheterization, especially after long term of periodic catheterization, it is proposed to use it for 4-6 weeks, and when the balloon is filled, it should be replaced. But the biggest disadvantage is the bacteriuria, and the appearance is about 10% per day, and but also the catheter through condom, it's also convenient, but latex in condoms can bring to damages to penis, to swelling, to necrosis, and even death related to these complications. As for other method of urination is reflect urination. Despite this motivation is performed by other nerves, and that lead to contraction of bladder and relaxation of the neck, and such reflect can be done when the hair from the above the genitalia can be turned off, and irritation of genitalia. Also, another method is the effect of Varsalve, and as an option is similar to following the trace, and today these methods they lead to complications and even to pyelonephritis and necrosis, and today we don't recommend them to use in routinal way, but it's enough to do the methods which were said before. As for the tissue engineering, today people study the stem cells as well on the basis of approach with frames. So the frames are used for development and differentiation of the cells. So this approach is using the stems or other types of cells for regeneration of bladder. Alternatively, it can be direct transplantation, and the transplantation of nerve stem cells that restores the nerve support of urination, and gene therapy also, including gene therapy for improvement of gene regeneration, and 3D printing with creation of special frames for support of cells. I think it is planned already in Rivne Hospital as well. What is not not the last but not least is a psychological support of the patients. The care should be very compassionate, and the family members also should live in their way of life, usual way of life. Psychological and medical and nurse support should be provided by the family members so that they would be capable to provide this assistance. They should be trained and to know how to train the functions of the bladder, and they would encourage the patient, and we need to provide them training. Thank you very much for your participation, and thanks to all who will help us to move on and overcome these difficulties.
Thanks for your very interesting talk. And may I mention that I really liked that you said one shouldn't overuse antibiotics, because in spinal cord injury patients who are somehow dependent on a catheter, you won't find a sterile urine. There's always bacteriuria. And the challenge is not to treat bacteriuria, but only symptomatic urinary tract infections, unless you plan an invasive procedure. But that is also, I think, a very important message, because these patients have to live with their bladder their life long. And we have to be very, very thoughtful of how much antibiotics we use in the first in this rehabilitation time.
Може, якісь питання є?
Maybe there are some questions. Thank you very much for the presentation. Professor Zaitsev, please, Chernitze. Question to Ms. Ruth. In terms of her opinion about alternative methods of bacteria treatment, vaccines like Razom, or maybe some drugs, plant-based. Do you think this would be expedient?
I mean, like urodynamic vaccination or some drugs, plant extract or something like that, if it's reasonable or not. What do you think?
Oh, I think that is a very promising approach. Actually, I am head of now nearly 10-year ongoing randomized trial to find a herbal medicine for to reduce urinary tract infection, to prevent urinary tract infection. Unfortunately, the results are not yet out, so I don't know, because it was blinded. But from my clinical use, I think using like anguzine, anti-infect N, or caniform, I don't know what the names are here, and also some kind of vaccination are very, one should use it. Also to make the urine a little bit more acidy, or I think we should try, and some people have like every second day take a sip of vinegar. Everything what is helpful to reduce urinary tract infections we have to embrace, because we know, like with herbal medicine, which has proven in the non-neurological society as effective, has no side effects. I mean, they don't get resistance against antibiotics, and that will be a big challenge for the future of these patients. I'm grateful for the question.
Ви задоволені відповіддю? Дуже дякую. Дуже дякую. Ще питання?
I'm satisfied with the answer. Thank you very much. More questions? I have a question to Professor Zaitsev, if I may. You deal with the problem of urodynamic studies for a long time as well. When, in your opinion, uroflowmetry is enough, and when, in your opinion, more detailed additional studies are necessary, invasive urodynamic studies, your experience? We are speaking about spinal cord injuries, or in general? In general, uroflowmetry should be, I don't know, like we all use ultrasound, like in all departments, yes. So principally, this is elementary method that may be performed within 5 minutes, and absolute majority of patients, especially with dysuria of incomprehensible genesis, why this is time of urination, why residual urine for patient. It helps determine obstructive type, and there's obstruction narrowing urethra, simply saying. You understand that when there is low urination rate, there are problems with voiding urine from the bladder, functional or anatomical. This is the most important. In this aspect, I would like to say, most important, take into account that the more urologist, as I understand here, also like I am a urologist, I think this is take-home messages after this session in this aspect as well. The main problem of these patients, spinal injury patients, do not die because of inability to walk. That they cannot walk, they may live tens of years to a larger extent. If there are no bed sores and so on, the main issue is infection, and the main issue is urinary infection. Majority of patients, unfortunately, have active contractions of urinary bladder that increase pressure. Like every liquid, urine wants to go out somewhere. If there's urine incontinence, this is better for them. That they better have incontinence, because otherwise if sphincter is closed or too closed, urine doesn't have way out. It comes back to kidneys. Reflux. Reflux is always infection. There's no way you may, what we're speaking about antibiotics, you may not prevent it, no way. So the principle most important that we may do to try to avoid pressure in the urinary bladder, so that this is too big. So catheterization, episosystoma, sometimes even surgery treatment, cut cervix as much as possible, so that urine, if the pressure goes up, goes out. This is the most we can do, or change urinary bladder. Surgical treatment, cystoplastics, this is very difficult. The only thing you may do is to make the urinary bladder less. It may prevent chronic infection and death from infection from constant pyelonephritis or kidney dysfunction. So patient may not necessarily feel this. You may not understand it if you don't understand what we're talking about, but this is the only thing that may save patients from this infection. Fortunately, antibiotics will not help you. Administer antibiotics, in 2 weeks pyelonephritis will come again if this pressure continues. This is the issue of those studies, to understand when, but the principle, big pressure in the urinary bladder, is the main problem for all those patients, and unfortunately this is why they're dying. Thank you so much. Thank you so much. Thank you for wonderful sessions and discussions. I'll invite everyone for lunch.
Вибачте, ще один анонс.
Excuse me,